Hello and welcome to another episode of Einstein's Eyes, where we take a closer look at the fascinating intersection between medicine, ophthalmology, anesthesia, innovation, private equity, mergers and acquisition, just really all things related to medicine and how the system works. I'm your co-host, Dr. Carl Rosen. I'm an oculoplastic surgeon and neuro-ophthalmologist, although these days primarily oculoplastic in Anchorage, Alaska at Ophthalmic Associates. My co-host, friend, colleague, and former co-resident, Jon Ditkoff from New Jersey. Jon.
Hello, everyone. Yeah, I'm a general ophthalmologist, been in practice for over 30 years, specializing in cornea in northern New Jersey, about 20 miles out of Manhattan. And it's always great to see Carl from the other end of the world. And nice to meet a new doctor and excited to hear about anesthesia.
Great. Thanks, Jon. So Luis Perez is an anesthesiologist at our surgery center, Geneva Woods Surgical Center, where he provides excellent anesthetic care for our patients, primarily ENT, Retina, Ophthalmology, and Oculoplastics. He's part of Denali Anesthesia. It's a wonderful group of anesthesiologists and CRNAs that provide care for our patients and allow us to do what we do. So Jon and I invited Luis on the channel today to discuss how he thinks about patient care from an anesthesiologist's vantage point. And it's really important for folks to know how, what the pros and cons of certain medicines are, how to prepare for surgery. And most of these surgeries are pretty short surgeries. We're outpatient surgical center. I do want to say that we, in Anchorage, we just had one of the worst storms ever. We had winds up to 100 miles an hour, gale winds, sideways snow, trees coming down. So we had power outages. So Luis had his neighborhood out, I had my neighborhood out, but we converged just at the right time. The universe is right, and we are here today now for this recording. So Luis, tell us about yourself, and then we'll jump in as far as the role of an anesthesiologist in an outpatient surgery center goes.
Great, thank you so much. So my name is Luis Perez. I grew up in Texas, and I went to medical school in Houston. Then I went to residency at Vanderbilt, Nashville, and then I came to practice in Anchorage. I'm really happy with practicing in Anchorage. Here in Alaska, we do independent practice, whereas in the lower 48, it's a lot of supervisory models. And so I really wanted to do my own cases. And also we have well, he's 2 years old now. We had a baby, now he's a 2-year-old infant and toddler. And it's a really good mix in terms of being in the outdoors, and we've been really happy here.
Let's start with the overview, Luis. So what does the preparation process look like for an anesthesiologist when you work with ENT, retinal surgeons, or ophthalmology patients in general, especially in an outpatient surgery center?
Yeah, that's a great question. So I'll start with what's similar really to all cases, and that includes primarily proper patient selection, especially in a surgery center. So anyone with any unstable disease, looking at somebody who has maybe some active cardiac conditions or pulmonary conditions, seizures, morbid obesity, maybe any recent infections, these would all be things that we'd want to look at to prepare for any case. And then after we find that someone is safe to have surgery at a surgery center, and luckily we have excellent intake nurses who help prevent any surprises on the day of surgery in terms of making sure that these patients have already reviewed by an anesthesiologist beforehand, so that they don't necessarily show up on the day of surgery and end up getting canceled for any reason. We never want that. But assuming that all checks out, then we think about the specific cases. And also, I like to think about the patient in their bigger picture, right? So a lot of times they have tremendous anxiety from maybe previous surgeries, or sometimes maybe the surgery is rather urgent. like a retinal detachment or something like that. And so you really want to look at the bigger picture too. And then ultimately you want to look at what's required to keep the patient safe. And that requirement is going to be different based on whatever case you're doing. So for ENT, for example, these patients often require general endotracheal anesthesia. And because a lot of times you're operating in the mouth and you maybe get some blood, some drainage, and you want to go ahead and keep the lungs safe, keep the stomach safe from any of that bloody drainage. And so, whereas in ophthalmologic surgery, a lot of times you don't require general endotracheal anesthesia because the heavy hitter there is going to be some sort of nerve block, right? And so, when we look at defining anesthesia, right, is the lack of sensation of pain. So you can achieve this in several ways. In the case of ophthalmologic, it's often with a nerve block. And so you kind of really see what's required and then sort of tailor to the patient-specific needs for that surgery.
As far as oculoplastics goes, I mean, speaking from where I'm coming from, we use local blocks with some propofol or Versed or fentanyl just to keep the patient sedated so they don't remember the anesthetic process. They don't remember the needle stick. We don't want them to have any recollection of that or any memory of that. And then once I give local anesthesia to, say, the eyelid or to the anterior orbit, most of my stuff goes pretty quick. My cases are usually about 30 minutes. Ptosis cases, blephs, dacryocyster rhinostomies, orbital fractures, those types of things. And then cataract surgery, which you also, take care of because we do a lot of cataract surgery, is awake. And it is a peribulbar block or a retrobulbar block or, a 6 to 20-minute procedure. Retinal surgery, as you mentioned, is longer, and most of those patients go under anesthesia, go under general, because a detachment or a scleral buckle or a vitrectomy, that's a little bit more, you can have more complications and you could run into more trouble. So you can't have patients squirming or moving around, and you have to keep them really still. And that's the best way to do that. And that requires the airway management, as you said, considering the cardiovascular stability, the positioning, the airway management. We are also concerned with drug interactions. And, I'm always worried about aspirin or anticoagulants, and we tell patients, you got to stop aspirin for 10 days if that's possible. And they discuss that with their cardiologist or their internist. Anticoagulants, 3 to 5 days. I like, Xarelto, those types of drugs, because they can really cause a lot of bleeding. But with these new drugs, and John and I did a slightly controversial recording on Ozempic. What kind of things are you concerned about with Ozempic?
Well, Ozempic, so Ozempic is a drug in a larger group of drugs called GLP-1 receptor agonists. And so the GLP-1 receptor agonists are what they're going to basically cause is they're going to tell the patient their own physiology that the patient is full, right? And so you're eating less, but you're also going to be slowing down the gut, slowing down the stomach emptying, with the overall goal that a patient is eating less, having less calories, having an overall improvement in their diabetic care. And so that's the goal. But when it comes to anesthesia and coming to surgery, it causes a pretty big problem for us, which is delayed gastric emptying, right? So if the stomach is full, or we have reason to believe that it's full because you're taking medication that is slowing down the emptying of the stomach, that can cause what's called an aspiration. And so an aspiration would be essentially puking up of the stomach contents and then having that go into the lungs. And this would be possibly food that was last eaten, also stomach acid, which can cause a very, very, very big problem. And so that's the overall concern, right? And so most patients are aware that they need to stop eating or drinking before surgery. Oftentimes it's 8 hours, and then really it's also 2 hours for clear liquids. But when you're on Ozempic or patients on Ozempic, the fasting guidelines really haven't been studied, but all we know is that it takes longer for the stomach to empty. And so those fasting guidelines really are not really applicable, but so we come down to the guideline for how long to hold the medication instead. And so if we're holding the medication for what's thought to be its therapeutic window, then we could say, okay, their stomach is resume their normal function and they go back to the normal fasting guidelines, normal NPO guidelines. So the latest guidelines from the ASA, the Association of Anesthesiologists, is dependent on the dosing frequency. So some of these GLP-1 agonists are dosed on a daily basis, but most of the common ones are dosed on a weekly basis. So Mounjaro and Ozempic, those that are on a weekly basis, it's recommended to consider holding it for the week before surgery, right? So that would be the recommendation. For the daily ones, it would be to hold it on the day of surgery. And then that brings us to, and really that is what we should be doing in terms of the recommendations for holding these medications in order to reduce the risk of aspiration, because there's really no reason to have an aspiration in a patient who's undergoing elective surgery, because these elective surgeries can be postponed to keep the patient safe, right? And so it's all about patient safety. Then we get into a kind of a gray spot. What happens if it has not been held? And then there's other factors, right? Like, so what if this isn't urgent surgery for retinal detachment or something else? Then that's a gray zone. And because it's urgent, then you would presume that the patient has a full stomach, and then you would proceed with full stomach precautions, right? And so there is a bit of a gray zone there. However, the guidelines are to hold the medication for either a week or on the day of surgery for the daily dosed medications.
What about anticoagulants? Do you worry about those?
Yes, so anticoagulants, really, it depends. It depends on what they're on, why they're on it, and the biggest factor there is going to be on the surgeon, right? So it depends on what is it going to do on the surgical field, what's the concern for bleeding in the surgical field, and what is the recovery going to look like. So ideally, all these things kind of line up. And ideally, it's not a big deal in terms of bleeding or be able to reasonably get good control. Ideally, they're not on it for a critical reason, and they are able to hold it. And so oftentimes, oftentimes they are able to hold it. And so that's why we want to see really cardiology note or some sort of recommendation from the cardiologist in terms of that patient's specific disease and the recommendations to hold or continue. But
that I'll pipe in, because as an anterior segment surgeon, not doing retinal surgery, for at least 20 years, our standard of care has been very simple. For cataract surgery, glaucoma surgery, corneal surgery, we do not stop anticoagulation. And the reason we don't is because, generally speaking, the risk to benefit ratio for those procedures is greater to stop the medication. So there's a reason if someone's on it as an anticoagulant, and the risk me surgically to do a cataract procedure to an avascular part of the body is essentially nothing. So we tell every single patient the same thing. And I've been saying this sentence for over 20 years. There's a very, very small risk of bleeding, like a retrobulbar hemorrhage, when you do cataract surgery or you do a block. And the thing is, the risk of that is lower than the risk of stopping your medication. And then I'll say, but if you want to run that by your doctor, if he says you really don't need it, great, stop it, because there's a very small risk that if you were to be the one that bleeds, it'll be worse. It'll be a worse bleed. It won't be caused by the anticoagulation. It's just that because you're anticoagulated, it'll be more difficult to control and it'll be worse. So that's pretty much like the risk of retrobulbar hemorrhage from a block or from the surgery is so rare. So that's been our standard of care for many, many years. But for eyelid surgery, that's very different, like what Carl's doing. So that's, I mean, I just wanted to pipe in for that.
Yeah, I mean, I can give you a little story. I had a patient on Xarelto, and she had cognitive issues. She had dementia, and she forgot to stop the Xarelto. And I always tell them, please stop at least 3 days, maybe 5 days.
Yeah,
But she needed a transfusion from a blepharoplasty.
Yeah, that's a big deal.
And that really hit home. That's why I'm so careful now. And but atrial fibrillation is the big one that the cardiologists are concerned about, because you don't want to flip an emboli and have a stroke. But retinal detachments aren't really elective, you know,
Yeah.
they have to go. If I have a facial fracture and it's impinging on the optic nerve, you know, or it's impinging on the globe, if you have a lateral orbital wall fracture, the zygoma, or a tripod fracture that's pushing on the globe, and every time they look laterally or the AB duct, they hit the bone, you have to do something, you know?
But like
So
Dr. Perez pointed out, I think this is really I mean, I think the blood thinner aspect is more surgeon dependent than anesthesiologist. I mean, anesthesiologist. Now, I have a question for you guys. In your surgery center, who does the blocks? Who does the peribulbar and retrobulbar blocks? Does the surgeon do it?
surgeons do it, yeah.
So most of the surgery centers in New Jersey that I've worked at, the anesthesiologists do it. So it is a little bit tricky because if we don't, let's say we don't stop the blood thinner, the block is actually one of the most dangerous parts of the procedure because you can get a
Yeah.
retrobulbar hemorrhage from the block. But I still think as a surgeon, we're taking responsibility for anything near the eye. Like that's kind of our decision. So we generally have allowed it to happen. Let them stay on blood thinners. I have a question for you though. I'm curious how you would handle this. So patient has cataract surgery done. 2 to 3 days later, a wound dehiscence is noted. So basically the wound is not intact. The surgeon books the patient semi-urgently. I wouldn't say it's an emergency, but yeah, you want to get that wound closed because the longer the wound is not closed, the higher risk of infection is to that eye, which can be vision threatening. So you book the case, patient comes to the surgery center for local procedure, probably not even a block, probably topical to do this procedure. And then the nurse sees that the patient drank water in the waiting room. So the nurse says to the patient, so when's the last time you ate? I haven't eaten in 12 hours, but I drank water. Would you cancel that case? And would it be your decision? Would you tell the surgeon? How would you handle that if the nurse came to you as the anesthesiologist?
No, if the case is being performed under local and you could be reassured that you get reasonable control of any painful stimulus with that local, and it needs to go urgently, then there's really no reason that it should be canceled at all.
So water would not be an issue to you.
Sorry?
Water would not be an issue, that they drank some fluids.
No, also because if it's being performed under primary local, you also don't need to provide any sedation, which is the fact, because you'd be achieving anesthesia. If the patient has tremendous anxiety or other things, then now we're getting into the gray zone of whether or not we should postpone it or not. But if it's water, then the guideline would be 2 hours, and hopefully maybe there's other patients that could be moved ahead. Either way, you make it work.
So really, for the 2 hours for water, you're doing it because of sedation, just that they could asphyxiate if they're sedated enough, I guess. Is that the idea?
Yeah. Yeah.
Great.
Thanks.
So let me ask you a question, Luis. So are there any advancements or trends in anesthesia that have changed your approach to ophthalmic surgeries?
Well, the big one would be regional anesthesia, right? And so with the development of regional anesthesia, peribulbar blocks, and there are also more advanced blocks I've been seeing recently. With that is essentially the heavy hitter. That is what's providing the anesthesia. That's what it's allowing the surgery to be performed, right? Anything outside of that is really patient comfort. So dealing with anxiety or anything else, and as you were saying, recollection of the injection. Regional anesthesia has been really quite tremendous for that aspect, and then other things would really the end-tidal CO2 monitoring is key, pulse oximetry, and being able to really tailor an anesthetic to exactly what a patient needs, but also keeping them safe is huge.
What percent of the cataract procedures that are being done at your facility are being done topically, just eye drops as opposed to blocks?
Yes, so the patients are getting the eye drops, and then they're also getting the blocks, and then
So they're all getting blocks, it sounds like.
And minimal sedation.
Yeah. So
Well,
John,
we do a lot of surgery just topically, just numbing drops. That's it. No injection.
the retina docs at my surgery, we have 3 retina docs at Geneva Woods, and they're not doing that. And then we have ophthalmologists that come in and do cataract surgery and cornea surgery. And then there's me that does the oculoplastics. But the cataract surgeons are not, they did do topical anesthesia and they've
And then it's-
reverted back.
Oh, interesting.
Hmm.
Yeah, I mean, I get that. I think there's definitely an argument that you're weighing risks and benefits, and there's nothing worse than an uncomfortable patient is danger to themselves.
Yeah, yeah. So
A
you
higher
take
risk
it,
during the procedure.
absolutely. You take a surgery that's movement or anxiety, and it happens so quickly, John. You know that.
Yeah.
'Cause,
Oh, do you
we-
tape everyone's heads for eye surgery? Is the head taped?
It's
Or is that-
surgeon dependent. Surgeon dependent.
What do you
I
think
don't.
the percentage is? Yeah. Do
I
have-
haven't seen the other guys do it. Luis, have you seen them tape their head?
No.
As far as the patient goes, what advice would you give to patients about communicating with their anesthesiologist before surgery? Do you have any final takeaways for the audience watching this video? What should they know and what should they ask their anesthesiologist?
Well, I advise patients to really communicate their concerns. Oftentimes they've had previous anesthetics, and with those anesthetics, they may have had problems with those, and that would be something we want to prevent because we already know that they're maybe prone to a certain problem, for example. Any family history, sometimes the problems with anesthesia can be genetic, and so we'd want to know that as well. Motion sickness, people with motion sickness are increased risk of maybe having some nausea afterwards too. And these are all things we want to know. But a final takeaway would be anesthesia is a wonderful field, right? We get to keep patients safe and help them through these very, very intense moments in their lives when they're undergoing surgery. I believe that patients or just people should try to go their entire life without needing surgery, right? But if the need arises, we're always here to help. We're always here to help, and I think transparency is key. And just talking about all your concerns, we do the very best we can.
I have one last question, only because your first sentence about being happy in Alaska and your primary role as opposed to supervisory. I think that's what you said.
Yes.
So just to clarify that for me, I mean, I want to make sure I'm understanding it. So you're saying that there are other opportunities to work as an anesthesiologist where I guess nurse anesthetists are in the rooms, and then those anesthesiologists are more supervisory. Is that what you were alluding to?
Yes, very common framework is a supervisory model where there's a group of nurse anesthetists and they're being supervised by an anesthesiologist, physician. That's a very common model in many states. As far as what we do here in Alaska, most of Alaska is going to be independent practice, and so with that, the nurse anesthetists are not being necessarily supervised, right? So it's an independent practice for nurses and nurse anesthetists. And with that, also the anesthesiologists, the doctors are also doing their own cases and are not in this model where they're overseeing a group of CRNAs.
Okay.
And so that's something I really wanted to do myself, because when I was going through residency, I had amazing training, but on an overnight call shift, I always felt not always. I often felt very strong, very strong confidence and clinical judgment in those who had been in private practice doing their own cases before joining academics, where academics is entirely supervisory model, at least in most cases. So that's kind of what inspired me to do that. And Alaska is a great place for that. There are a couple of pockets, like in Washington, and other places that that there is independent practice and the anesthesiologists are doing their own cases, but by and large, Alaska is the majority. That is the majority.
Thanks again for joining us here on Einstein's Eyes. We appreciate our audience. We thank you for being here. If you found value in this, please like and subscribe, and we will see you on the next one. Good seeing you, everybody.
Thanks, everyone.